Hey everyone, welcome back to the channel. Today we're tackling one of the most high-yield topics in all of medicine: the drugs we use to treat type 2 diabetes. Whether you're a student cramming for exams or a doctor who wants a fast, clean refresher, this is your one-stop tour. We'll go mechanism by mechanism, class by class, all the way through the ADA 2025 and NICE 26 guidelines. I'm going to keep it tight, practical, and clinically real, so grab a coffee, hit subscribe, and let's get into it. Quick roadmap before we dive in, because I want you to know exactly where we're headed. We start with the foundations: how the disease works, how we diagnose it, and how we pick a target. Then we walk through every drug class, hitting mechanism, pharmacokinetics, efficacy, and side effects. After that, we translate all of it into the actual treatment algorithms and finish with special populations and safety. You can watch this straight through as a study path or jump to any chapter. Let's build the foundation first. Here's the big idea that unlocks everything. Type 2 diabetes is not one broken thing. It's a whole team of organs misbehaving at once. Insulin resistance plus a slowly failing beta cell. The liver's pumping out too much glucose. Muscle and fat won't take it up. The pancreas under-secretes insulin and over-secretes glucagon. The gut's incretin signal is blunted, and the kidney is happily reabsorbing sugar it should dump. And here's why that matters. Every one of those arrows is a drug target. That's why we combine agents, and it's why this whole lecture makes sense. Keep this map in your head. Let's nail diagnosis, because you will be asked this. Any one of these 4 criteria makes the diagnosis: an IHUNT of 6.5 or higher, a fasting glucose of 126 or more, a 2-hour OGTT of 200, or a random glucose of 200 plus classic symptoms, 1 ketchup. Unless the patient is unequivocally hypoglycemic, you confirm with a repeat test. And watch the affix traps. This is where people lose marks. Anemia, hemoglobinopathies, pregnancy, recent transfusion, all make it unreliable. When in doubt, pad the APUNT with a fasting glucose. Now, what number are we actually aiming for? And the honest answer is, it depends on the person. For most adults, under 7%, push towards 6.5 if you can get there safely without hypos. But in someone older, frail, or with a limited life expectancy, chasing a tight number does more harm than good, so we relax it to 8 or even higher. NICE says the same thing in different words. Agree the target together and set it by how likely the drugs are to cause hypoglycemia. Tighter targets, safer drugs. That's the theme. This slide is the mindset shift, and it's genuinely changed how we practice. The old game was simple: rank drugs by how hard they crush glucose and stack them up to hit a number. The new game is completely different. We look at the whole person first: their heart, their kidneys, their weight, their hypo risk, and we choose drugs that protect organs. Here's the line I want you to remember: SGLT2 inhibitors and GLP-1 agonists are now recommended for heart and kidney benefit even when glucose is already at target. That's a paradigm shift. Say it with me. Before we go deep, Here's the whole toolbox on one slide, so you've got a mental filing cabinet. We've got insulin sensitizers, metformin and pioglitazone, secretagogues that squeeze the beta cell, the sulfonylureas and glinates, the incretin family, DPPP4 inhibitors, GLP-1 agonists, and the dual agonists. Then the glucoceuric SGLT2 inhibitors, the carb-blocking alpha-glucosidase inhibitors, and of course insulin itself. Every drug we discuss lives in one of these boxes. Let's open the first one. Chapter 1, and we start where every patient starts: metformin. This is the foundation, first line for almost every adult with type 2 diabetes. It's been around forever, it's dirt cheap, and it still earns its spot at the top. Let's find out why. So how does metformin actually work? At the core, it activates AMP kinase, essentially flipping the cell's low energy switch. The headline effect is in the liver. It tells the liver to stop overproducing glucose. It also nudges muscle to take up more sugar and tweaks the gut. Crucially, it does not squeeze out insulin, so on its own, metformin does not cause hypoglycemia. Love that. Pharmacokinetics, quick and clean. It's not metabolized at all. It's cleared unchanged by the kidneys. That single fact drives everything about dosing, which is why we care so much about eGFR. The modified release version is gentler on the gut, and NICE now prefers it. Clinical reality time. Metformin drops ACA by about 1 to 1.5%. It's weight neutral or even helps a little, and no monotherapy hypos. Fantastic starter. The side effects, mostly the gut, nausea, diarrhea, that metallic taste. The fix is easy: start low, go slow, take it with food. Long term, keep an eye on B12. And the one everyone fears, lactic acidosis, is genuinely rare, but you respect it. Avoid it below an eGFR of 30. Hold it during acute illness, dehydration, or sepsis, and pause it before contrast scans and big surgery. Know those rules code. Chapter 2, the secretagogues, the drugs that go straight to the beta cell and say, "Give me more insulin now." That's the sulfonylureas and the glinites. Powerful, fast, cheap, but as you'll see, that direct push comes with a price. Let's meet them. Sulfonylureas. They bind the SORN receptor on the beta cell, slam the potassium channel shut, and force insulin out. And here's the key word: glucose independent. They push insulin whether the sugar is high or not, and that is exactly why they cause hypoglycemia. Solid efficacy, around 1 to 1.5%, rapid and cheap. The trade-offs are hypos and weight gain. Please avoid glibenclamide in older adults. It causes nasty prolonged lows. Reach for glyclazide or glimepiride instead. And remember, they lose steam over time as the beta cell fades. Not the most durable option. The glinides, ripaglinide and natiglinide, are basically the sulfonylureas quick-acting cousins. Same channel, different binding site, but the personality is different: fast on, fast off. You take them with each meal to knock down the post-meal spike. The slogan writes itself: no meal, no dose, which makes them handy for people who eat on an unpredictable schedule. Lower risk of those between meal and nighttime hypos than sulfonylureas, and ripaglinide is liver cleared, so it's an option in kidney disease. Example, Both classes hit the same channel, so both bring hypoglycemia and weight gain. Don't get caught out. Now we hit my favorite chapter, the incretins. This is where modern diabetes care gets exciting. DPP-4 inhibitors, GLP-1 receptor agonists, and the new dual GIP-GLP-1 agonists. To use them well, you have to understand the physiology first. So let's start there. Here's the beautiful bit of biology behind the whole class. When you eat, your gut releases hormones, GLP-1 and GIP, that tell the pancreas to release insulin. That's the incretin effect, and in type 2 diabetes, it's blunted. GLP-1 is the star. It boosts insulin, but only when glucose is high, so low hypo risk. It calms glucagon, slows gastric emptying, and hits the brain satiety center, so you eat less and lose weight. The catch: the DPP-4 enzyme chews it up in minutes. That gives us two clever strategies: block the enzyme or replace the hormone with a resistant version. One rule though: never combine a DPP-4 inhibitor with a GLP-1 agonist. Same pathway, no point. Strategy 1 and block the enzyme. The gliptins, sitagliptin, linagliptin, and friends stop DPP-4, so your own incretins hang around longer. They're the easygoing members of the family. Oral once daily, weight neutral, very low hypo risk, and generally super well tolerated. The trade-off is modest power, only about 0.5% off the A1. A couple of safety flags: watch for rare pancreatitis and avoid saxagliptin in heart failure. There's a hospitalization signal. And a nice fact to file: linagliptin is cleared through the bile, so no renal dose adjustment. The others you adjust. Now the heavy hitters, the GLP-1 receptor agonists. These are DPP-4 resistant analogs, so instead of a flicker of incretin, you get sustained, powerful receptor activation. That means strong glucose lowering, 1 to nearly 2%, plus serious weight loss and low hypo risk. This is a lot of clinical value in one injection. Delivery is mostly subcutaneous. Once weekly stars like semaglutide and dulaglutide, daily options like liraglutide, and there's even an oral semaglutide, take it fasting with plain water. One golden rule with all of them: titrate up slowly to tame the gut side effects. Patience pays. So why has this class taken over? 3 letters: outcomes. GLP-1 agonists cut major cardiovascular events in landmark trials like LEADER and SUSTAIN 6. They drive substantial weight loss and they slow kidney disease. That's protection, not just glucose control. The side effects are mostly the gut nausea, vomiting, diarrhea. Usually transient, and titrating slowly is your best friend. Watch for gallbladder issues and rare pancreatitis. And the hard stop: you must memorize a personal or family history of medullary thyroid cancer or MENAN2. Absolute contraindication. And these are not insulin substitutes. Never use them in type 1 or DKA. And now the new kit that's rewriting the record books: tirzepatide, a single molecule that hits both the GIP and GLP-1 receptors. 2 incretin pathways at once means the biggest glucose drops and the biggest weight loss of anything we've got right now. It's once weekly, and the side effect profile mirrors the GLP-1 agonists, mostly gut, so you guessed it, titrate slowly. Same thyroid cancer contraindication applies, and cardiorenal and fatty liver data are stacking up fast. The big picture: incretin therapy is treating diabetes and obesity together, and that's a genuine game changer. Check your local formulary before you prescribe. Chapter 4, and honestly, this might be the most important class we cover, the SGLT2 inhibitors. They started life as glucose-lowering drugs, but the story that made them famous is what they do for the heart and the kidneys. Let's dig in. The mechanism is beautifully simple. SGLT2 sits in the proximal tubule of the kidney and reabsorbs glucose. Block it and you pee the sugar out. Glucosuria on purpose. Because it's insulin independent, it works no matter what the beta cell is doing, and hypo risk is low. Bonus effects: you lose a bit of salt and water, so blood pressure and preload drop, and you shed a little weight. Now the key nuance for exams and clinic: the glucose lowering effect fades as kidney function drops. But, and this is huge, the heart and kidney protection persists even at low eGFR. So check the eGFR, follow the label, and don't write it off just because the sugar effect is small. This is the slide that changed the guidelines. SGLT2 inhibitors don't just lower glucose, they keep people out of the hospital and slow kidney decline. Fewer heart failure hospitalizations, slower progression of chronic kidney disease, and reduced cardiovascular death in high-risk patients. That's outcome data, not surrogate markers. And look at the trial roll call: EMP-A-EG, KMVS, and declare for cardiovascular, DAPA-AF, and EMP-ROR for heart failure, working even in people without diabetes, and CRNCE and DAPA-CKD for the kidneys. This is one of the great success stories in modern medicine. No free lunch though, so let's talk safety, because counseling here is everything. The common one is genital yeast infections. Just warn people up front. Watch for volume depletion, especially with diuretics or in the elderly. Utis happen, and canagliflozin carries amputation and fracture signals. But the one that must never leave your brain is euglycemic decay, ketoacidosis with a near normal glucose, so it's easy to miss. That's why every single patient gets the sick day rule: stop the drug during acute illness, dehydration, or before surgery. Counsel every patient, every time. Chapter 5 is a quick but important 1A. The thiazolidinedians really just pioglitazone these days. It's a true insulin sensitizer that works through the nucleus. A bit old school, a bit under-used, but it has a real niche. Let's see where it fits. Pioglitazone is a PPAR gamma agonist. It literally turns on genes that make muscle and fat more insulin sensitive. It takes a few weeks to kick in, but the A1C drop is durable. There's no hypoglycemia, and because it's liver cleared, you can use it in kidney disease. It may even help fatty liver. But, and it's a big but, the side effects define its use. Fluid retention means it's contraindicated in moderate to severe heart failure. Full stop. Add weight gain. Increased fracture risk, especially in women, a bladder cancer signal, and rare macular edema. And you can see why we pick our patients carefully. Chapter 6 is our catch-all: the insulin itself. These are the players you reach for in specific situations. So let's round out the toolbox. Quick tour of the extras. The alpha-glucosidase inhibitors, acarbose and miglutal, block carb digestion in the gut so your post-meal glucose rises more gently. Take them with the first bite. Modest effect, weight neutral, no solo hypos. The catch is flatulence and diarrhea, which honestly limits how often we use them. And a classic exam point: if a patient on one of these has a hypo, treat with pure glucose, not table sugar, because they can't break the sucrose down fast enough. There are a handful of minor agents: pramlintide, cosevelam, bromocriptine, rarely used, and fixed dose combos that boost adherence. Every choice balances efficacy, comorbidity, hypo risk, weight, and cost. Insulin. It can feel intimidating, but if you organize it by how fast and how long it works, it clicks. Rapid acting, like Lispro and Aspart, cover meals. Regular is the slower mealtime insulin, and it's your workhorse in DKA. And MPH is intermediate. The long-acting glargine, ditimer give you a flat basal profile. And premixed splits the difference for twice daily convenience. The whole logic is this: basal insulin controls the fasting and overnight glucose, prandial insulin covers the meals, and basal bolus together mimics what a healthy pancreas does. Master that framework and the rest is detail. So when do we actually start insulin and how? You reach for basal insulin when the A1 stays stubbornly high despite oral agents and maybe a GLP-1, or when someone's symptomatic with severe hyperglycemia. Start simple, around 10 units a day, then titrate against the fasting glucose, nudging it up every few days until you hit target. If meals are still out of control, advance to basal bolus. Two modern points though. GLP-1 agonist is usually the preferred first injectable now, not insulin. And keep the metformin going, but rethink the sulfonylurea to avoid stacking hypo risk. Educate hard on hypos and weight gain. That's the deal with insulin. Alright, we've built the pharmacology. Now for the payoff, chapter 7, where we put it all together into real guidelines. ADA and ESD 2025, NICE NG28, and how you actually tailor this to the patient in front of you. This is where you become genuinely useful on the wards. This is the money slide. Screenshot this one. Every class side by side on the metrics that actually drive your decision. Look across the columns: how much A&T drop, weight up or down, hypo risk, cardio benefit, and the key caution: metformin, safe and neutral. Sulfonylureas and insulin, powerful but hypos and weight. GLP-1 and SGLT2, the modern stars with weight loss and organ protection. If you internalize this one table, you can build a rational regimen for almost any patient. It's the whole lecture in a grid. Here's the ADA and EASD approach, and notice how person-centered it is. Lifestyle, weight, and metformin form the supportive foundation, but the first real question isn't the glucose number. It's: does this person have cardiovascular disease, heart failure, or kidney disease? If yes, you reach for a GLP-1 agonist or SGLT2 inhibitor with proven benefit, independent of the A-rank or whether they're even on metformin. Then, where glucose lowering is still the goal. You match the intensity to the gap, and the hypo risk want weight loss. GLP-1 or tirzepatide want to minimize hypos, favor the safer classes, and always be willing to de-intensify. Now the NICE 2026 update, and this is fresh, so pay attention because it's a real shift. The headline: dual therapy, Metformin plus an SGLT2 inhibitor, is now offered first line to prevent complications. And if there's established cardiovascular disease, you go straight to triple therapy with semaglutide added. That's assertive early organ protection. To apply it, assess the whole picture: obesity, heart, kidneys, frailty, individualize the target, and talk through each drug's effect on weight and outcomes. Don't forget sick day rules, and if metformin is not tolerated, and SGLT2 inhibitor steps in. Let's make it patient specific, because the exam and real life both love this. Match the drug to the dominant problem: cardiovascular disease, GLP-1 or SGLT2 with proven benefit. Heart failure, SGLT2 is your friend, and avoid pioglitazone and saxagliptin. Kidney disease, SGLT2 for protection, and those are just the renally cleared drugs. Obesity, lean into GLP-1 or tirzepatide. Older and frail, avoid hypos, ditch glibenclamide, and relax that target. Pregnancy, it's insulin, and stop the other oral agents before conception. One patient, one tailored plan. Safety chapter, and this is the stuff that keeps patients out of the ER. First, hypoglycemia. The high-risk trial: insulin, sulfonylureas, and granites. Remember Whipple's triad and the 15-15 rule: 15 grams of fast carbs, recheck in 15 minutes. If they're out of it, glucagon or full glucose, and that alpha glucosidase catch again, treat with pure glucose, not sucrose. Then sick day rules. Think Sadman's, the drugs to hold during acute illness or dehydration. Stop the SGLT2 to dodge euglycemic DKA. Hold metformin with dehydration or contrast, but never stop insulin in type 1. And always give it in writing. Okay, if you remember nothing else, remember these 10. Metformin still first line. Choose by comorbidity, not just glucose potency. SGLT2s protect heart and kidney, GLP-1 seconds, cut cardiovascular events and drop weight, and you use them independent of the APOM when there's organ disease. NICE now goes dual first line, adding semaglutide if there's cardiovascular disease. Secretagogues and insulin carry the hypo risk. Counsel every SGLT2 patient on DKA and sick days. GLP-1 beats insulin as the first injectable. Individualize the target, and always confirm the dose against your local formulary. That's the whole deck in 10 lines. And that's a wrap. Everything you just heard is anchored in the ADAA 2029 for Standards of Care and the NICE NG28 update, plus the key reviews you see listed here if you want to go deeper. One honest disclaimer: this is an educational resource, not a substitute for full prescribing information. Always verify doses and contraindications locally before you treat a real patient. If this helped you make sense of diabetes pharmacology, smash that like button, subscribe for more, and drop your questions in the comments. Thanks so much for watching, and I'll see you in the next one.